5:30. Let's go ahead and get started with our first Brummer Colloquium speaker series for this semester. And our guest speaker for this evening is Dr. Michael Nadorff, who is an associate professor of clinical psychology at Mississippi State University, one of the best schools in Mississippi. He received his undergraduate degree from the University of Notre Dame and his master's and PhD in clinical psychology from West Virginia University. And he did his internship at the Baylor College of Medicine in Houston, Texas. Dr. Nadorff is a specialist when it comes to suicide research and suicide prevention research. And a lot of his suicide research intersects with themes like sleep and nightmares, which you'll hear a little bit about today. And for the students in here, I think this talk will be a real treat if you're interested in a research path. How do you sort of get to the point where you're getting millions of dollars in grants, that you have over 90 publications and these H indexes and all the other things that we use to say how great we are when it comes to research. And for me personally, it's a real treat for me to have Dr. Nadorff here. I've known him for about 10 years now.
About, yeah.
Since I started working in one of his colleagues' labs when I was an undergrad, in my early 20s, very early 20s. And he has since been a mentor to me, teacher, supervisor. He was on my thesis committee, on my dissertation committee, wrote me a letter of recommendation for this job, so I owe a lot to him. I think he's a really great guy, and with that, I'll give it away to Dr. Nadorff here. Please welcome.
Thank you so much. It's really an honor to be here. I was so excited to get the invitation. This is also one of my favorite talks to give, so I'm really excited. And one thing to start out, just show of hands, how many of you are faculty? Okay, grad students and undergrads. Beautiful. That's what I was hoping for. So this is a different type of talk, as you'll see. There's a lot of research in it. We're going to talk a lot about my research program and where this area of research is. But you may notice that there's an asterisk on this, and you may wonder, why the heck is it? There's kind of a subtitle to this talk, and that is how the heck did I get here? Because I think that's one of the great mysteries that I had, certainly in undergrad and as I went. And so let me go to my immodest slide. And I always feel kind of guilty putting this up, but I remember being in undergrad and even through grad school, looking at the CVs of my faculty and being like, how does someone do that? So I stopped and looked at my own. So I have 90 peer-reviewed publications. With those, for those that don't know what an H index is, I have 29 pubs that have been cited at least 29 times. So it's like, okay, those pubs are actually making a difference. I've gotten over $8 million in grant funds from different federal agencies. I've graduated some PhDs and a postdoc, and I'm president-elect of the Society of Behavioral Sleep Medicine. All that's pretty cool, and I didn't actually ever anticipate I'd get into sleep. We'll see how I got there. How does one get there? And with that, it actually all starts before I was born. So this is my grandmother. This is Leona Marie Briola Roy, who died by suicide in the 70s. And one of the things that really struck me was this was a family secret. I was actually told until high school that she died of cancer. And my dad let slip when I was a freshman that it was actually a suicide. And it really struck me. It was, and when I looked back, I could see the ripples of the effects of the suicide throughout my family. And it just made me really wonder, how does someone get to the point that they're so miserable that they may think of ending their life? And I thought, well, the good news is I'm going to go be a psych major. This is one of the biggest questions in psychology. So clearly we will have answers to this. And then lo and behold, when I got into studying psychology, I realized a lot we don't know, including really what leads someone to suicide. We know predictors. We know, risk factors. but we're still horrible at predicting suicide. There's a meta-analysis done in 2017 that looked at 50 years of suicide research. Couple interesting facts from it. One, in the last 50 years, we have gotten no better at predicting suicide than we were. Two, if you look at clinicians, we're about only as good as chance at predicting who will actually die by suicide. So I just want to stay on that for a second, just because if there's one thing that you take from this, I don't want it to be the research, I actually want it to be this point. There's so many families I worked with that have lost someone to suicide, and they looked at the end and they're like, how did I not know? How did I not see this? And there's guilt. There's this guilt that's associated with that. I want you to know, if that ever happens to you or a friend, that even under the best circumstances, trained clinicians, licensed clinicians, get it wrong half the time. This is really hard. And there's a lot we don't know. And so I realized this in undergrad, and I realized that if someone with a personal connection with this topic wasn't going to study it, who is going to study it? It's hard research to do. There are special precautions you have to take. And, it's not the most exciting thing. They're the people that study children, and that's cool. I study nightmares and suicide. They're like, how do you get up in the morning? Well, it's life-changing stuff. It's life-saving stuff. It's one of the few life-saving topics we have. But how did I get here? Because I couldn't just start with studying suicide. And actually, my freshman year, I was at Creighton University. And it all started with Intro to Psychology. So like so many of us, I was in Intro to Psychology. And I joined the lab of my Intro to Psychology professor, who is Dr. Nancy Stone. And she did research. She's an IO psychologist. And her research was on teamwork. And she was doing a study looking at this flight simulator game where 3 people would work together to accomplish a goal. And so my job in the lab was watching videotape for hours on end, coding every behavior, and trying to interpret what was the behavior intended for. Were they trying to seek information or request assistance? Something very different than the work that I ever wanted to do. But it was also a very important first step into research. It was my very first experience. And I learned a lot about research, but also I learned that part of doing research is sometimes doing the grunt work that you don't want to do. But it's an important first step. It's part of paying your dues. So after that, I transferred to Notre Dame. And at Notre Dame, there wasn't anyone doing suicide work, but there was Dr. Anita Kelly. So her main area of research was, what secrets do you keep and why do you keep them? But also, she was an interesting person so Notre Dame is about an hour away from Chicago. And so she was a psych professor by day. And then on the weekend, she'd go and she'd play in high-stakes poker tournaments that were underground in Chicago. And so with that, she's always kind of interested in risk-taking behavior, especially in terms of gambling. And always looking for an edge. But I saw a connection. I'm like, suicide's a risk-taking behavior too. Okay, I'm interested in this. So I started learning about risk-taking in terms of high-stakes gambling. And in doing it, I found a study that I guarantee you've never heard of. You're lying to me if you tell me you've heard of it. I'm sure all of you have read Spittle, 1976. As I remember, it was published in the Australian Journal of Psychiatry. I don't even know why or how I came across this study, but I found this interesting, where it was looking at those who were depressed and those who were not depressed. And it was looking at their risk-taking. And what we see is on the left, or I guess, yeah, your left too. Okay, good. We see a normal distribution for risk-taking, and that kind of made sense. But for those who were depressed, it was really interesting in that they showed a bimodal clustering towards the extremes of risk. And I got thinking about why that would be. And I thought, you ever hear someone say, I did this because I wanted to feel alive? Could that be maybe someone's efforts at self-medicating? Could people engage in risk-taking behavior to try to work out of a mild depression? Maybe it's that those who are less depressed will actually be more risk-taking, and those who are more depressed, maybe they show less risk-taking behavior. So it got me thinking, and it led to an honors thesis. So any of you do an honors thesis or grad students? Anyone? Who's done an honors thesis? Just me? Okay, well, you can think of doing an honors thesis. This was actually our fancy, we programmed this computer program. It's very fancy. So we recruited 73 undergraduate students for a gambling study. And this was because we were not good programmers, we were psychology students. This is a game called AC Doocy, which I'm not sure if you're aware of. But so you have two cards, and you're betting on the likelihood that the card that pops up in the middle is between those two cards, which we liked because the probabilities of this are pretty easy to calculate compared to a lot, and we were undergraduates. So it was a nice way to actually be able to look at risk-taking, in a way that we could figure out. So we did that, and this was our procedure. We had people come into the lab, and this is when I'll just tell you what we did without judgment, because now, knowing what I know, there are so many things I'd pick apart with this study, but it's like, I didn't know better. I was an undergrad. I was just doing the best I could and learning how to do research as we went. So we had people fill out the bet depression inventory to kind of get a sense of what their baseline depression was. We did a first round with this card game, but it was manipulated because, we had to do something, devious. We're psychology students. So the first round is manipulated either to be 80% win or 80% loss. So my advisor wanted to know, what happens when you're on tilt, when you're on a streak, and how does that affect your risk taking? For me, I was kind of using it as I was using it as a mood manipulation, essentially. So my thought was if you lose more, then they'll lead to more negative affect, because we actually did have money tied to this. I had a small undergraduate grant to fund this. So we had them fill out the PANS to look at affect. Then we had a second round where they got to do it without our manipulation, and we looked at their risk-taking behavior to try to see, how does that initial round, that manipulated round, affect it? And then we did debriefing at the end. So what did we learn? So what was interesting is, consistent with what you see with gambling, having that winning streak in the first round was related with riskier betting. And also positive affect was related and correlated with risky betting. So it has interesting implications for the gambling literature, but also it was really interesting for me because what I saw was, I did see there was a difference when you looked at the depressed, and the depressed, again, aren't really that depressed. They're college students, but nonetheless, you saw a difference by condition if they won initially or if they lost with how risky they were. And again, it's just a first step where it wet my whistle as far as research with risk-taking and how to do this. What else did we learn? This was a funny story, and I tell all my graduate students this. There's an important lesson. You won't be able to read this. This is in our handbook, and I'll read it to you, or not our handbook. This was the yearbook. So it was Res Life Stories. Res Life is our dean of students. When you get in trouble, you go to Res Life. My friend did his senior psychology thesis on gambling, and he set up an experiment based on poker, passed out flyers to advertise for participants, and then received a letter from Res Life accusing him of setting up an illegal gambling ring. That happened. So this was at the peak of online gambling way back in the day. And when that started getting shut down, what they did is a lot of those groups started shifting to universities and had that gambling done in the dorms. So all the rectors were told, watch out for illegal gambling. So yeah, I got turned in for illegal gambling, which was kind of ironic because I did a study that was funded by the university, approved by the IRB. Now, what did I learn from this? This was an important lesson because I was so flippin' embarrassed because I was a rule follower. I do not get letters for res life. So I told no one. I went, I defended myself. By the time I got there, they figured out what happened. They sent me home. I went and I talked to my advisor. She's like, why the freak did you not tell me? I'm like, I was embarrassed. I didn't want to admit what happened. She's like, I could have gotten you out of that. Why didn't you tell me? Always tell your faculty advisor. You're under their supervision. Do not keep secrets like this. But you can get a fun story out of it and get written up in the yearbook. I also got my first publication out of it, which is pretty cool. So we got published in the Psychology of Addictive Behaviors. So that was really neat. So then I went on to West Virginia, and I entered the clinical psychology program there under Dr. Amy Fest. Again, I'm a suicide guy. That was my focus. But my very first year, I was in a sleep medicine clinic, and I loved it. I loved the interventions. I loved working with people with insomnia and nightmares. And my very first client was a mid-40s engineer where he had actually been forced into early retirement because his insomnia was so bad, he couldn't keep doing the job. And after getting CBTI, he was able to go back to work. And I thought, this is literally life-changing stuff that we can do here. That's really awesome. And so it inspired me to think about, how does sleep fit with suicide? Is there a way I can build this into the research I want to do? And there's a study that had come out a couple of years earlier that found that nightmares were associated with suicidal thoughts, and that was independent of depression. And I'll be honest, I was not impressed by this study. I know the authors very well. At the time, I was not impressed by this study because I was looking at it and I'm like, well, sure, it's not associated with depression, but think of nightmares. You're thinking PTSD, you're thinking anxiety. I'm like, if they had just controlled for some of these other variables, I don't think nightmares would have been associated with insomnia. So it led to my master's thesis, where we had a sample of 500 undergraduates, and we examined the association between insomnia, nightmares, and suicidal thoughts, and looked at whether or not these were independent of depression, anxiety, and PTSD. I know you can't see this, but I'd just like to show that I actually did all the I did all the things. I controlled for all the variables. Blown up. What was interesting is that after controlling for all those, insomnia symptoms, while they were initially associated with suicidality, were not associated with suicidality. But nightmares were significantly associated with suicidal thoughts, independent, so statistically accounting for depression, anxiety, PTSD, and insomnia. Dang, I was wrong. And to this day, this study is still my most cited study. But one of the things I got thinking, at the time there was I knew there were nightmare treatments at the time, obviously, but I got thinking about it. I'm like, why don't we do nightmare treatments with those who are suicidal if they have nightmares? And there was some anecdotal evidence that perhaps doing nightmare treatment might lead to a short-term increase in suicide risk, so we shouldn't do it. And I just got thinking, yeah, but what about if you have nightmares for a long time? Isn't that associated with suicide risk? And of course, that was a variable I hadn't asked, so I had to do another study. So I did another study. So again, college students on this one. We had 673 undergraduate students. And very similar study. We were investigating nightmares and insomnia in relation to suicide risk. But this time we added in a measure of duration. This wasn't really, and by duration, that's the word I published with. Chronicity would have been a better word. Basically, we had a retrospective item on just like, how long have you had insomnia? How long have you had nightmares? And what we found, again, did all the stuff, but blowing it up to make it easier to see, controlling for depression, anxiety, PTSD, insomnia, and nightmares. Actually, we found that both duration of insomnia and nightmares were associated with suicide risk. So what we are finding is, in this one, actually, the current symptoms were not as important. In later studies, they end up being important too. But chronicity was really important. And so that ended up being a vital piece, because now I actually have data showing, well, you're worried about possibly the impact of a brief treatment on nightmares, on increasing suicide risk. But we now have data showing that if you don't treat them, if you just let them go, the longer you have them, the worse it gets with suicide. So that was cool. And now I got thinking, I want to understand why nightmares are associated with suicide. We know it's not depression, it's not anxiety. Why the heck are these associated? So, did another study. So this one was once I had gone to MSU. Harris on there is actually my very first undergraduate RA. Weiner on there is Dr. Jordan's advisor. So we investigated the same things. You'll notice a theme, like we're not reinventing the world with each step. It's just the next study up. We took the same items and we looked at it within the interpersonal psychological theory of suicide. Don't worry if you don't know what that is. I'll explain in a second. So this is the leading theory of suicide. And I had a feeling that it wasn't going to explain nightmares, but also a big part of this, there's a little ego when you come up with a theory. So the authors of the theory thought that it explained all of suicide. So with that, just to make sure my bases were covered, the second author, Mike Anestis, was one of the primary grad students who had worked with the person that developed the theory. So what we did is we independently at our different schools got the same sample, so 2 college student samples, 2 different large public universities, to see, okay, can this leading theory of suicide explain what's happening, why nightmares are associated with suicide risk? So what is this mystical theory that I keep talking about? And I'll actually skip to the next slide and show you the graphic. The thought is that there are kind of 2 pieces to it. First, you have what made someone desire death by suicide. So what made someone, suicidal? And what made someone so they can actually do it? Because to actually die by suicide, you have to overcome the greatest instinct we have, which is self-preservation. That's really hard. Thankfully, most people can't do that. That protects a lot of people. So as far as desire suicide, that piece, there are 2 pieces to it. There's thwarted belongingness, which is a fancy way of saying loneliness, disconnection, and perceived burdensomeness, which is a feeling like your death is worth more than your life. People would be better off if you weren't here. So the thought is that those 2 factors combined make it so you desire suicide. And then there's this third group. There's this group that is those who are capable. In the theory, it's called acquired capability. The thought is that these are people who either through their own experiences or vicariously have observed pain and suffering to the point that they've kind of habituated to it, so they can overcome that self-preservation instinct. So with it, this theory leads to a lot of interactions, and I tested them all. Again, you're not going to read any of that, but again, I show in my work. What I found is that, and this was in the first study, this was my data. Controlling for that entire theory, nightmares were still significant. Then I decided to get cocky and try to control for depression too. And they were barely missed significance there, 0.054 controlling for depression. But that was controlling for depressive symptoms and that entire theory and all it explains. So that was for suicide risk. But we also looked at suicide attempts, which was interesting. So looking at that, again, showing my work, nightmares were associated with suicide attempts controlling for the entire theory. And even after I controlled for depression, nightmares were still associated. Now take a second and look at that depression one. How much is this theory explaining? It's explaining so much variance that depression's not associated with suicide. Like, that's a lot of variance. there's something unique about nightmares. I'm not saying it's more important than depression, to be clear, but there's something unique about nightmares that's not being captured by these other measures. But these are my data. You know, maybe I'm biased towards this. I've been doing this line of research for a while. So what about someone else's data where I had nothing to do with it and his advisor came up with the theory? His data were stronger than mine. So he also found that nightmares were associated with suicide attempts. And again, when we controlled for depression, nightmares were still associated. Interesting stuff. Now, got me thinking, and you know, at this point, I have students and they have theses they need to do. So, you know, it's the point in my career where I can get some good ideas and be like, hey, you should do this study. So that's exactly what I did. So I had Dr. Katrina Speed in my lab. And you know, I was thinking, you know, we know that the strongest predictor of suicide is a past suicide attempt. One of the things that people don't look at much is what leads someone to attempt once or more than once. You know, what leads to multiple attempts? And wouldn't it be interesting if nightmares were, you know, particularly important for predicting multiple attempts? Now, to be clear, I wasn't the first one to think of this. There is a study that inspired me that's actually one of my favorite studies. Sjostrom and colleagues, 2009, followed 165 individuals who had attempted suicide for 2 years, looking at what predictors predicted future suicide attempts. And what they found was having nightmares put you at fourfold, so 400% increased risk of a future suicide attempt after they controlled statistically for depression, anxiety, PTSD, and substance use. Again, I'm not saying it's the biggest predictor, I'm saying it's an important one that's not being considered. So I was wondering, you know, can we find that, you know, similarly in a different way? So we were looking at what predicts those who attempt suicide more than once. And we used a slightly different strategy. We recruited from Amazon's Mechanical Turk. I can get into what that is if you're really curious, but I'll save that for now. And lo and behold, so we had 96 individuals who had attempted suicide once in their lifetime, and we had 105 that attempted more than once. So what factors differentiate these two groups? What makes them different? Lo and behold, out of all these, depression, PTSD, anxiety, insomnia, the only one that statistically differentiated those groups was nightmares. But what about nightmare duration? Sure enough, it did as well. And they were independent. So it's not just how strong, how bad your nightmares are right now, it's also how long you've had them. And both of those factors independently were differentiating those groups. So, to recap, nightmares are associated with suicide. Nightmares predict future suicide attempts, controlling for several risk factors. And we know that the longer you suffer, the worse it gets. We still don't fully understand the mechanism. There is research, including a couple from my lab, that play into this. I just didn't have time to throw them in. Emotion regulation seems to be a piece that, you know, is underlying part of this, but there's still a lot more we need to learn. But I was presenting on all these data at a conference, and a psychiatrist friend of mine came up to me after and he said, Michael, at the end of the day, it doesn't really matter why they're associated. We need to just treat the darn things. That's fair. So with that, we started kind of making a pivot towards nightmare treatment. And so I want to tell you a little bit about that, because I think one of the promising things about this is not just that I can show that nightmares are important. This is something we can do something about. We actually have a really good treatment, which a lot of people don't realize. So what is a nightmare, first and foremost? So a nightmare is a frightening or disturbing dream that awakens an individual. So it's actually that startled awakening. It happens during REM sleep, which happens more during the second half, the later half of sleep. So with that, one of the telltale signs, like if you ever wonder, what's the difference between a nightmare and a night terror? In a night terror, since that comes from non-REM sleep, you're not going to have very much of a recollection of a dream, or it's very vague if you do. A nightmare, you're going to have a very strong recollection of a dream. It's going to be a vivid one. Also, in a night terror, you're going to wake up and be very disoriented. Nightmares, REM sleep's a much lighter stage of sleep. You're going to wake up and be instantly alert, oriented, aware of your surroundings. And it differs a little bit from bad dreams theoretically. That's a whole different debate for other, for my sleep friends. Technically, a bad dream is a bad dream that does not have that startled awakening. It's that startled awakening that makes it a nightmare. This is DSM-5 criteria. Grad students, let's pick on just the grad students. I'm going to talk about this slide. I want you just to figure out what's wrong with the criteria. Nothing else, just what's wrong. So what we see here is it's repeated, well-remembered dreams. Again, the well-remembered is important. That tells us it's not a night terror. It's coming from REM sleep. During the second half of the night, that's also REM sleep. You become instantly awake and alert. And of course, it's not better explained by other medical or psychological complaints. Okay, grad students, time's up. What's wrong with this criteria? How many do you need to have this? Repeated, right? What the flip does repeated mean? So if I've had 2 nightmares in my life and it's the same nightmare, do I have nightmare disorder? So that's the thing. For some reason, and they didn't ask me, they didn't care what I thought, but clinically it's not very useful because for everything else, like depression is like have 5 of these 9 symptoms. Well, that's easy. You have 5 or you don't. Here it's like, well, how many do I need to have? Well, the answer is, usually for clinical studies, we use 1 a week as the clinical threshold. So if you're using this clinically, just remember, if you have a nightmare that's 1 a week or more, that's usually clinical threshold, or if it's causing distress. But DSM doesn't tell you that. So the prevalence varies by age. So we know that about 20% of children will have weekly nightmares. Many of us with kids know that. But it doesn't go away that much. We start to lose it as we age. But even as college students, and I don't think it's just that it's West Virginia or MSU college students, the other MSU, the southern one, mine, 14% of college students still report weekly nightmares, which is a lot. And what was interesting is only 1/3 of them have clinically significant PTSD symptoms. So actually, a lot of them, what it looks like is they just never outgrew their nightmares from childhood. And even into old age, 4.3% of older adults still report having weekly nightmares. So this is a very prevalent disorder. You don't hear about it a lot because people don't talk about their nightmares a lot. That's a whole different story I can get into. Or actually, I have it on the next slide, so I will get into it. But one of the problems that we run into is that people don't realize that either their nightmares are abnormal or that anything can be done. So I did a study where I just looked at those with at least weekly nightmares. And only 37% had told any healthcare provider at any point of their life about their nightmares. And so I asked why that is. And one that was a very common response that was interesting is, well, I have nightmares every night, but doesn't everybody? Well, no, they don't, but how would you know that? Unless you're talking to your friends and comparing notes, how do you know what's normal? Here's another one, grad students. I'll give you a chance to redeem yourselves. I'm going to come back to you for what's the normal amount of nightmares, so just ponder that for a second. The other thing is that less than 1/3 of the individuals believe that nightmares are treatable. Why would you tell the doctor about something that the doctor can't do anything about? Well, there are treatments. There's a pharmacological and there's a couple behavioral treatments. We'll talk about one of them. But people don't know that. Okay, so what is considered a normal amount of nightmares? Very good, yeah, 1 a month or less. But 1 a month is pretty average. So very good. You redeemed yourself. So everyone thinks about nightmares and PTSD, and this makes sense. Like it is a very telltale, symptom of PTSD. And we know that it's a lasting symptom. So nightmares and PTSD can last 50 years or more. But what I want you to pay attention to is the second point. I think it's really interesting. The presence of nightmares before trauma makes it more likely for you to develop PTSD. This is not just a symptom. This is a risk factor for PTSD. I won't spend much time here because I want to make sure we have time for questions and answers. So I'll just briefly touch on it's associated with depression and anxiety as well. One that surprises people, there's a decent relation with schizophrenia and nightmares. So you can see here that the prevalence of nightmare, or among nightmare sufferers, and this is an old study, I'll give that caveat, that's just done with DSM-3R, but nonetheless, if you want a thesis, you can redo this. If you looked within nightmare sufferers, the prevalence of schizophrenia and schizotypal personality disorder is really high. You're talking 11% and 16%, much higher than you'd expect in the general population. Also, nightmares are a common symptom just before a relapse of schizophrenia, and they correlate with the MMPI psychosis subscales. So, whole nother area of research. I haven't really gone into it, but they're important there too. Nightmares, if I've convinced you of very little, hopefully I've convinced you, nightmares are clinically significant. You know, they really, really are. The good news is we have a really good treatment for it. So imagery rehearsal therapy is the most widely researched CBT-based nightmare treatment. It is now the recommended treatment for nightmare disorder and also for nightmares associated with a trauma. It can be done individual or group format, and it's done in 1 to 3 sessions. It's brief. We can do this very quickly. And that's part of the reason why I was always so taken with this. Like, this is something you could actually do during an inpatient stay, you know, whereas most treatment, you don't have time. So I first always show the data before I tell you how to do this treatment. Because this treatment is so simple, you won't believe me that it works unless I show you the data. So let me show you the data. So this was Barry Trakow in his 2001 JAMA paper. I always like to lead with that because it's JAMA. It's like the journal. 168 females survivors of sexual assault with PTSD. And he compared imagery rehearsal therapy to a waitlist control. And what I love about this treatment, and you'll see it in this slide and the next, it's broad. It doesn't just help nightmares, it helps other things too. So these are Cohen's D's. If you're not familiar with them, it's how big an effect is. So anything over about 0.8 is a large effect size. So what we see is a large improvement in nights with nightmares and also total nightmares, and a medium effect size for sleep quality. But we also see a large effect size improvement in PTSD symptoms. And these, persisted for 6 months. So these are actually really lasting treatment effects. This is the study that I call my cheater study because they did IRT and they also added in CBTI for insomnia. So it's not just IRT, to be clear, but I love this one because it shows how broad this treatment is. So 62 victims of violent crime. Again, we see a large effect size improvement in nightmares and insomnia and PTSD. But look at depression and anxiety. Those are medium effect sizes. Like if you were doing a depression study, you'd be happy with those results. Just by treating the sleep, we get that. So these are treatments that really have a broad impact. You get a ton of bang for your buck out of them. Which leads us to the Holy Grail, and we're just scratching the surface on these data, but can we reduce suicidality with nightmare treatment? So I have a couple of drafts here of preliminary data where I'll talk you through them, and there's also a huge, really laughable lesson learned that we had that shows why you do the research. So looking at the right, I did this with Tom Ellis at Menninger Clinic, and so first of all, a brief thing on Menninger Clinic. This is an inpatient hospital, long stay, where people pay about $2,000 a day to be there. It's not a place you can really do an RCT because when you're paying $2,000 a day, you don't want to be in the comparison group. So what we did was a simple study of, we had our people with nightmares, and we split them on who said yes to the treatment and who didn't. So it wasn't randomized, but we at least had a comparison group. So the green line is the group that got imagery rehearsal therapy. The blue line is the group that turned us down. All of them were receiving treatment as usual at the clinic. And what we see is that actually the green line, those that accepted the treatment had worse nightmares starting out than the group that didn't receive this treatment in addition to everything else. But they improved at a much faster rate and actually ended up on suicidality below the group that did not receive imagery rehearsal therapy along with treatment as usual. So that's one piece of data that's early but really, I think, interesting and influential. The lesson learned. So actually, we almost made a huge mistake on this, and I'll fully admit that. So Von McCall is that psychiatrist friend of mine that told me, it doesn't matter, we need to treat it. So prazosin is the medication that you can use to treat nightmares. So he was comparing in a small study, about 20 people, prazosin versus placebo on nightmares. And these were the data we got where what we saw was one group had significantly lower suicidality at the end of treatment than the other group. And at the time we were writing the grant on this, it was before the blind had been removed. So we looked at it and we're like, okay, we know the prazosin's outperforming. We went ahead and wrote a grant to Department of Defense to try to do a larger study on this. It did not get funded, and thank God it didn't, because actually when we removed the blind on it, the red line's the prazosin. The green line is the placebo. Placebo outperformed the prazosin on suicidality. Oh boy, that would not have been good. You ever been thankful that you didn't get grant funded? I was. That would have been embarrassing, but it shows why we do the research. There needs to be more research, and I give Dr. McCall a lot of credit. He published this. People don't usually publish their findings, and I remember I sought him out when the data first came out. I saw him out at a conference. I'm like, what happened? And he pulled out his phone. He showed me a picture. He said, I was so surprised by this finding. I went and I found the research pharmacist and had her show me the bottles to make sure they didn't get mixed up somehow, because it surprised me that much. But so apparently with suicidality and nightmares, you don't want to use prazosin. So I do all this stuff. I talked about why nightmare treatment might be helpful. This is why you still have to do the research, because sometimes you get those, like, apparently not. So just a couple things I wanted to mention. So how do you get to that point at the end with those publications and those grants and all the stuff? Be curious. If you looked at the stuff I've done, none of this is that I was brilliant. None of this is that, I just stumbled across the best idea ever. What this was is that I did a study, and then I was like, I wonder about this. And then I did the next study and the next one. And it just builds. Also, follow your data. All this became, I'll be honest, I'm at this stage in my career, I'm probably better known for my nightmare work than my suicide work, which is ironic because it all started with me not thinking nightmares were that important. But what I did is I followed my data. I didn't try to explain it away. I didn't try to twist the data in some way that it wasn't. I said, I guess I was wrong, and I kept going. So follow your data, and then think of what the next step is. Do research that's meaningful to you, but also know that, it all starts somewhere. It may not be doing the research you want to do. It may be coding tapes of people doing teamwork research when you really want to study suicide. That's okay. It may also be doing suicide research when you want to do teamwork research. Embrace wherever it is that you start, get the experience. You're going to learn a ton from it. Also, just one thing I have to throw out, because we have a bunch of undergrads here, some master's students, and I know you don't have a PhD in clinical psych. I have to put on the training director hat. Please consider applying to my program. We have 2 PhDs over at MSU, the Southern MSU. We have a clinical psych and a cognitive science. Both are fully funded with tuition waivers and all that. So please consider that. Here's my contact information. I did it just about right, Dr. Jordan. You mentioned 15 minutes for questions. We have it. So I'd love to hear any questions or thoughts you have. Yeah. Well, that's a great question. So I still really want to do the suicide treatment or the nightmare treatment for suicide. Getting that grant funded has been really hard, but I'm still trying. I just haven't found the right home for it. But what I've been doing a lot of work on, and I was telling the graduate students about it earlier, is we did a shift upstream in my lab just because that's where both grant funding was and also where there's a need. So we're doing a lot of suicide prevention training all over the state of Mississippi. We have a grant where we can provide free training in Mississippi for both prevention and postvention. Postvention being like what you do after a suicide, how you respond to stop a contagion effect. So we have that going on. We have a lot of cool trainings going on. We are doing trainings for first responders on de-escalation and mental health awareness. We're doing a drug-free community grant. So we have a lot of kind of upstream prevention stuff, but I still really want to get back to that treatment part because I do firmly believe, even though I'm almost sure IRT would work well, I only have pilot data. I want to do a real, fully, powered study showing that IRT is effective because I do believe you need to do the research, and I learned that the hard way. So I still want to do that study, but in the meantime, doing a lot of trainings and prevention work at a broader community level. I've had this before. I don't know if you heard it. It was actually, my watch was asking me if I wanted to call the suicide hotline. It listens to you, and I will have that happen in meetings because I taught so much about suicide. But it is good to know that it's there. If you don't know, 988 is the new number, though the old number still works too. But a lot of people don't memorize 1-800-273-TALK. It's just people like me. So know that hotline is there. Siri will remind you. Other questions? Oh, I thought you had a question. No. Okay. Yes? Oh, thank you. I forgot to do that. I talked about how it's so simple you won't believe me, and I never told you about it. Okay, yes, thank you. So here's all this is. So you have the person come in with their nightmare, right? I have them write it down just vaguely. It's not meant to be an exposure-based therapy, so I have them write it down so I know kind of what the dream's about. And then I tell them, change it any way you want. Change who's in it, change where it is, the setting, and add superpowers. It's a dream. Anything you can do in a dream, you can do in this. The only rule is I want you to change it enough so it's a dream you'd want to have. Not just be willing to have, not less scary, a dream you'd want to have. Once you have that, you have the person write it, first person, present tense, and then you have them practice that using visual imagery about 2 times a day, 5 to 10 minutes each time. And usually one of 2 things will happen. And if you're wondering why, I'll tell you. Yeah, I can get into the nerdiness, but usually either the person will just stop having the nightmare or they'll start having the new dream. So one of my favorite stories and examples of this was when I was working at a VA, and I saw a veteran where he had this recurrent nightmare of his job was he'd drive to the front lines with the bus, pick up the soldiers, bring them back. And he had this recurrent dream that he was driving with a bus load of soldiers, it was getting to be dark, and just this fear overcame him that this is when something really bad can happen to me and I'm a sitting duck. And then he'd wake up. So I said, okay, change it any way you want. What do you want this dream to be? He said, well, I want to be driving my minivan. I want my kids in the back. I want us to go to a park. And one of my biggest regrets is that my dad died before my kids were born. I want my dad to be there. I want him to meet my kids and see him play. So I said, okay. So we write down the dream. Next session, I come out, veterans crying in the waiting room. And of course, I'm still a trainee. So my initial thought is immediately, I have screwed up. What have I done wrong? I'm going to be in so much trouble. So I pull him back. I'm like, what happened? He said, I started having that new dream. And there's such a meaningful experience for me. And I thought, how cool is that? Here's a veteran that both had it where he's not having his nightmares, and he had this experience that was obviously extremely meaningful to him that he really wanted to have. I thought that was really neat. So that's one of my favorite examples to kind of illustrate it. But yeah, that's all it is. You take the dream, change it any way you want so that's a positive one. Then you practice it using visual imagery, which is where you really picture it in as much detail as you can. Practice that dream, and then, yeah, you'll either stop having the other one or start having the new one. It works about 80% of the time. If it doesn't work, I have other options. You just email me and I can tell you about them. But it works most of the time, and it's a fun treatment to do. You know, I stress that it's not exposure-based. There are people that do it in more of an exposure way. I don't think you need it. Like, we have data that shows that you don't need it. And so another, talk about next steps, another study I really want to do, and this study was started, but then it was halted by DOD because they had some recruitment issues, so it needs to be redone. I honestly think for people that have PTSD and nightmare, perhaps we should start with a treatment like this. It can be done in 1 to 3 sessions. It's very well tolerated because it's not exposure-based. People enjoy doing this. Let's try this, see how well they are, because exposure therapies are great. I'm a behaviorist. I love them. They are the surgery of psychology. They're very effective, but we don't need to start with them. Let's start with medication. Let's start with behavior change. Let's see if we can avoid surgery. So that's my personal belief. But again, I'm a big believer that we always should do the research and get the data. But that's another study I'd really love to do. Other questions? Yeah. No, the follow-up was just for 6 months. Every indication, it lasts longer than that. Also, you can do it for more than one nightmare. So if you have other nightmares too, you just do the same thing after a couple of weeks just for the next dream and then the next dream. Another thing that people will ask, and so I'll just cover it in advance. What if my nightmares are all totally different and they don't really relate to each other? Well, a lot of times when you actually stop and look and kind of put the pieces together, there is a theme you can go off of. But even if not, and this is more anecdotal, I'll be honest, I haven't done the study, it's just from my clinical practice. You can still have someone re-script a new dream and do this, even if it's separate from the nightmare, and it's still effective. And again, I can get to the nerdy theory if you're really curious about it, but that can be done too. So it's a real versatile treatment. Other questions? Yeah.
I'm just curious if you've been doing research on looking at maybe realistic nightmares versus unrealistic nightmares on the internet.
There is. This is also kind of a funny story. So I did a study looking at content of nightmares in relation to suicide, and I had guilt about this study because there was a student honors thesis back in the day. We found some cool stuff. I never got around to publishing it, and I had guilt about never publishing it until I saw someone else do the same thing, and I was a reviewer. And usually you'd think you'd feel bad about being scooped, but I was like, oh, thank goodness someone did it so I don't have to feel guilty about not publishing my data. But the short version is there are differences based on content. They weren't huge, but what we did find is that for dreams or nightmares where the content was death, also, which that made sense. Also, supernatural dreams, for some reason, were more associated with suicidal risk than other types of nightmares or dreams. So, like, that's where your zombies, aliens, that sort of thing. So, I haven't really gone further down that path, but there are some indications that the content of the nightmare is important. Other questions? Yeah.
Considering your background, what is your perspective on prophetic and lucid dreams?
Okay, so with me being a behaviorist, I'm not a big believer in prophetic dreams. Certainly I've heard a lot of people talk about them, and I know I have clients that will tell me for sure that they happen. I'm just not there and believe it. Lucid is an interesting piece. So if you're not aware of these, lucid dreams are dreams where you are aware that you are dreaming while you're having them. And actually, remember how I said if you fail with this treatment, call me? The second treatment that I'd recommend, the backup, is lucid dreaming, where you can actually teach people how to be aware that they're dreaming while they're having the dream So while you're having that nightmare, you can actually change the nightmare while you're having it. So it's a different story. And another funny story with this. So MSU decided to do this big write-up on my nightmare treatment stuff. And I found a client that was willing to be in the story. It's all fantastic. So all that was great. It's one of the few clients I had fail IRT. Just did not work for her at all. But lucid dreaming worked for her. So if you look in our alumni magazine, there's this huge write-up of me doing therapy, which I do like once every 3 years. But of course, that's what gets featured. It's like, yeah, that's how it goes. But I thought that was kind of ironic. But yeah, lucid dreaming is, it happens, that's what it is, and it can actually be used as a nightmare treatment as well. Yes?
Can sleep paralysis fall into this?
Great question. So sleep paralysis is often caused by, essentially in REM sleep, your body will paralyze itself so you don't hurt yourself or others. With that, when you're coming out of sleep, you can have it where your brain wakes up, well, part of it before the rest of it. So you can still have it where your body's paralyzed, but you're awake. So that's the sleep paralysis part. It's usually not associated with nightmares, but what you can see, so sleep paralysis, if you have it a lot, can be a possible sign of narcolepsy. And narcolepsy is also actually associated with nightmares. So it's not likely directly associated with nightmares, but it may be indirectly through narcolepsy. Good question. Related to that, there's also hypnagogic and hypnopompic hallucinations where you wake up and you see your dream. Same thing, part of your brain's in REM sleep, part of your brain's awake. So you can actually have hallucinations where you're seeing it. Now, for both that and also the sleep paralysis, just to put you at ease if you've ever had this. If they happen every once again, but they're rare, that's normal. Nothing wrong with you. You know, that's okay. If they happen a lot, similar, could be narcolepsy, but for most people, it's actually normal that you'll probably have this happen once or twice in your life. Don't worry about it. Yeah?
Can you work with small children, teenagers?
Yes. Oh, kids are fun with these. So teenagers, you do pretty much the normal treatment. Kids are fun. You know, visualizations should be harder for kids, but you can have them draw it. And there aren't many studies that have been done with IRT in kids, but there are a couple that are very strong. And both of them showed if you have the kid draw the new dream, that works just as well. Great question. Yes?
What if the child doesn't know that it's actually a nightmare and they're very convinced that what they experienced is actually reality?
Mm.
You walk them through IRL when they don't know that it's something to be.
That is tricky, and I can tell you what I would try to do. I can't guarantee it would work, but what I try to do is, even if they weren't sure that, you know, what was real, what wasn't, I still try to stress that this is replacing that other experience. So this is going to make it so that other experience doesn't happen and you have this new one. So not trying to argue whether or not it's real, just saying we're changing this out and we're going to do this other path. That's probably what I try. Will it work? I don't know, but that's my best guess.
Did you notice that there was a correlation in your study participants over duration that it started in earlier childhood, or was it more like duration for the time that they are currently having nightmares?
So, good question. So, with the duration, a lot of that was those that where it started early on, but a lot of those they had both early and current. So, just a lot of people have it where it just never has relented. You know, they've just dealt with it for a long time. They just don't know to ask for help or for treatment, and that's part of why I love giving these talks. Is it's an awareness thing. You know, there's so many people that could benefit from these interventions, and they just don't know. I don't know if that answered your question, but I hope I got close. If not, you know, let me know.
Yeah.
Let's see. Okay, I know we have maybe one time for one more. I see one in the back. So nightmares are associated with suicidal thoughts. There's always the chicken or the egg, and you know, my data are cross-sectional, so I can't say which caused which, but we know that they're associated, and we have a little bit of data showing that if you get rid of the nightmares, you can reduce suicidal thoughts. But it's all, you know, that piece is preliminary, and that's where we really do need more intervention work. And I need to convince DOD or someone else that they want to fund me to do this. But I think it could be really impactful because, again, it's something, it's obviously being missed by the treatments we're doing, and it has a chance to move the needle. So just keep hoping that those grants get funded. I keep trying. But I can't say for sure which causes the other just with the data we have. So with that, as you can tell, I'm a nerd about this stuff. I love it. So I'll stick around as long as people are here to ask questions. But with that, thank you so much. I so appreciate the invite and being able to come and talk to you about this. Just thank you. I really appreciate it.